Today we are going to talk about acute renal failure, which is often referred to as acute kidney injury in recent times. This term has been around for quite some time now. In the early 18th century, it was first described by William Hebden. It was referred to as ischemia renalis or kidney failure because of ischemia. Subsequently, in the early 19th century, William Osler described acute Bright's disease, which referred to kidney injury as a consequence of toxic agents, pregnancy, burns, trauma, or any surgery on the kidney. And this was something like an acute renal failure. This term was more commonly used in the First World War, where they referred it to as war nephritis, and it was more of acute renal failure secondary to crush injuries. And Homer W. Smith introduced the term acute renal failure in a chapter on acute renal failure related to traumatic injuries. So in the next 1 hour, we're going to discuss about the definition and classification of acute kidney injury, epidemiology, etiology, pathophysiology, and an approach to prevention and management. So we know that the kidneys are the main excretory organs of the body. So what happens is blood from the systemic circulation enters the kidneys through the renal arteries. It is filtered and literally cleaned by filtering units known as the nephrons, where the filter is the glomerular basement is formed by the glomerular endothelium, the basement membrane, and the specialized cells called podocytes. The unnecessary extra water, wastes, and electrolytes are filtered out and excreted in the form of urine via the ureter into the bladder, while the necessary blood components, the necessary water, proteins, nutrients, and other ions are returned back to the blood systemic circulation via the renal veins. So when we talk about acute renal failure or acute kidney injury, it basically is a clinical condition characterized by the rapid worsening of this renal excretory function. Now, how rapid is rapid? When we talk about acute renal failure, we are usually referring to a worsening within hours to days. This leads to accumulation of products of nitrogenous metabolism like creatinine, urea, and other waste products. And when we talk about acute renal failure or acute kidney injury, it could be an overlap. It could be an acute worsening in a previously normal kidney, or it could be an acute worsening superimposed on an already diseased or chronically injured kidney. Now, this was what was known as acute renal failure in the earlier days, but now the definition has changed. So why was there a need for a new definition or classification? We saw that the glomeruli in the kidney are responsible for filtering the blood, or literally cleaning out the blood. So all these days, the glomerular filtration rate has been the best index of kidney function. It can be measured by various exogenous markers like the inulin clearance method, but these are time-consuming, expensive, and not feasible to be done regularly in clinical practice. So in clinical practice, the glomerular filtration rate or GFR is estimated from serum levels of endogenous filtration markers. The most commonly used in clinical practice is the serum creatinine. Using the serum creatinine, the estimated GFR is calculated using various formula, the commonly used formula being the CKD-EPI, the MDRD, and the Cockcroft-Gault formula. However, we need to understand that serum creatinine is not very sensitive in detecting the early decline in GFR. It starts rising. By the time it starts rising, there has already been a substantial decline in the GFR. So just measuring the serum creatinine and GFR, we may not diagnose acute kidney injury in an early stage. The other criteria till now used for acute renal failure was urine output, but the urine output may or may not decrease with renal failure. So when we talk about acute renal failure in the traditional sense, that is a rapidly worsening renal function, the earlier definitions did not adequately characterize the entire spectrum of disease. So what is acute kidney injury and what is the difference between acute kidney injury and acute renal failure? So when we talk of acute renal failure, there is a finality in it. The kidneys have already failed. But when we talk of acute kidney injury, it is rather a continuum of kidney injury that begins long before sufficient loss of excretory renal function can be measured by the standard laboratory tests like serum creatinine. So it defines it as a syndrome ranging from minor changes in biomarkers of renal function to severe loss of function requiring dialysis. And this continuum also extends to the prognostication of disease. There's a progressive increase in mortality, even with small rises in serum creatinine. So AKI is more of a spectrum rather than just a disease manifestation. This led to the development of the conceptual model of acute kidney injury. So an individual may have a normal kidney, which progresses to a stage where he's at increased risk of developing AKI. So he may have certain susceptibilities, or he may be exposed to certain risk factors which make him more susceptible to developing acute kidney injury. If no intervention is done at that stage, there may be actual damage to the kidney, and then subsequently there is a progressive decline in GFR leading to a stage of kidney failure which may require dialysis, and this increases the risk of death. So we need to identify the patients early, especially at the stage where they are at an increased risk, so that we can intervene and prevent their progression to damage and decline in GFR to improve the outcomes. Based on this thinking, various AKI classifications were brought up. In 2004, the Rifle criteria was given, which was a consensus definition of AKI by the Acute Dialysis Quality Initiative. And subsequently, there was the AKIN, or Acute Kidney Injury Network classification in 2007, which made minor modifications to the Rifle criteria. And finally, there was a new consensus definition of AKI, merging the Rifle criteria and the AKIN definition, given by the Kidney Disease Improving Global Outcomes Working Group in 2012. The Rifle criteria was based on serum creatinine and urine output. They defined risk as a rise in creatinine by 1.5 times, or an absolute rise of 0.3 milligram of serum creatinine, and or a decline in urine output to less than 0.5 ml per kg per hour for at least 6 hours. Injury meant a doubling of serum creatinine or a decline in urine output for up to 12 hours. Failure meant a rise in creatinine up to 3 times, or an absolute creatinine of more than or equal to 4 milligram per deciliter with an acute rise of at least 0.5 milligram per deciliter, with or without a urine output of at least decline in urine output of less than 0.3 ml per kg per hour for at least 24 hours, or anuria for 12 hours. And finally, it progressed to loss when there was a complete loss of renal function for at least 4 weeks. And we know that AKI, acute renal failure, can progress to end-stage kidney disease finally. However, it had some problems. So yes, Rifle criteria was defined by a rise in serum creatinine or a decline in urine output. But how soon is it? The point of rapidity or the timeline was still confusing. So AKIN tried to address that issue. They said that an abrupt decline in kidney function within 48 hours. So AKIN definition gave a timeline of 48 hours within which there was an absolute increase in serum creatinine of at least 0.3 milligram per deciliter, or at least 50% increase in serum creatinine from the baseline, or a decrease in urine output, which is a documented oliguria of less than 0.5 ml per kg per hour for at least 6 hours. Again, AKIN also had its issues. Yes, within 48 hours is fine, but what if we do not know the baseline serum creatinine before 48 hours? So this was addressed by the KDIGO classification. They said that an increase in serum creatinine by at least 0.3 milligram per deciliter within 48 hours, or an increase in serum creatinine by at least 1.5 times the baseline. And the baseline was defined as known or presumed to have occurred within prior 7 days. So if you do not have a baseline serum creatinine in the last 7 days, we need to find out indirectly, like, does the patient have any other evidence of chronic kidney disease or any risk factors from chronic kidney disease before deciding whether it is an acute kidney injury or an acute on chronic kidney injury. So KDIGO actually staged the acute kidney injury. They said stage 1 was 1.5 to 1.9 times rise in from baseline creatinine, or at least a 0.3 milligram increase with or without a decline of urine output for 6 to 12 hours. Stage 2 was 2 to 2.9 times rise in serum creatinine from baseline with an oliguria for at least 12 hours. And stage 3 was serum creatinine rising by 3 times from the baseline, or an increase in serum creatinine to at least 4 milligram per deciliter, or a condition where the patient requires initiation of dialysis, or in patients who are less than 18 years old, decrease in eGFR less than 35 ml per minute per 1.73 meters square. So KDIGO was the first classification system which gave an objective staging system for AKI. Now, having looked at the definition and classification, let's go on to epidemiology. So the incidence of AKI, when we talk about incidence of AKI, it varies based on the definition used to define the AKI, the population studied, and the severity of disease assessed. There are two types of AKI broadly. Community-acquired AKI, where the patient comes to the hospital with an acute kidney injury because of any reason. This is seen more frequently in developing countries because of tropical infections, venoms, and obstetrical accidents which commonly happen there. Hospital-acquired AKI means the patient is admitted to the hospital for some other reason and develops kidney injury therein. This is more common in developed countries and varies from 2 to 9%. AKI is especially common in critically ill patients in the ICU, most common cause being sepsis, and in these patients, the outcome is poor. AKI is a risk factor for the highest mortality rate. As I said earlier, the causes of AKI, other than the incidence, the causes of AKI also varies according to the geographical setting in which it is studied. AKI associated with hypovolemia secondary to diarrheal diseases is frequent in developed countries because of poor sanitary practices and overcrowding. Infections like malaria, leptospirosis, dengue causing AKI is more commonly seen in tropical and developing countries. Hospital-acquired AKI, especially post-operative, post-cardiac surgery AKI, is a common cause in developed countries. Etiology of AKI also varies with age, as I will discuss subsequently. Having looked at the epidemiology, let's address the common causes of AKI. So, when we talk about AKI, there are three types of AKI, broadly three categories. It starts with the blood supply to the kidney. We know that the kidneys receive 25% of the cardiac output. So any interference with the blood supply to the kidney will cause kidney injury, and this is known as prerenal AKI. Any abnormality in the structures of the kidney or the renal parenchyma will cause kidney dysfunction, and this is referred to as intrinsic AKI. And if the kidneys are working fine, if they're receiving good blood supply, but the urine produced is not flowing out because of some obstruction, it is referred to as postrenal or obstructive AKI. So when we talk of prerenal AKI, it's the most common cause of acute kidney injury, seen in 40 to 80% cases. It's caused by basically impaired perfusion of the kidneys. Initially, when the perfusion to the kidneys is impaired, the integrity of the renal tissues is preserved. There's a functional injury. And if the renal perfusion is restored at this stage, it results in prompt recovery of kidney function. But if there's sustained renal hypoperfusion, there can be structural damage to the tubules, which is referred to as an ischemic acute tubular necrosis, which then becomes an intrinsic cause of AKI. When we talk of prerenal AKI, it could be because of decreased effective intracellular volume, which could be because of actual volume loss. The volume loss may be due to GI loss because of diarrhea, vomiting, poor oral intake, or even excessive nasogastric suction. It could be because of hemorrhage, because of trauma, GI bleed, intraoperative, or a postpartum bleed, which is common in developing countries. Renal loss because of excessive diuretic use, diabetes insipidus, or even osmotic diuresis, and even loss from the skin in cases of severe burns or hypothermia. Sometimes there is no actual volume loss, but there is redistribution or third spacing leading to decreased effective intra-arterial blood volume. This is seen in cases like nephrotic syndrome, hepatic disease, peritonitis, pancreatitis, or intestinal obstruction. Sometimes AKI can also develop if there is a decrease in the cardiac output because of cardiac disease like congestive heart failure, myocardial infarction, myocarditis, valvular heart disease, arrhythmias, cardiomyopathy, and so on. AKI can also develop due to severe peripheral vasodilatation, which is seen with hypotension, sepsis, which is a common cause of AKI, anaphylactic shock, treatment with interferons, hypoxia, and hypercapnia. There can also be a decrease in effective arteriolar vasodilatation, efferent arterial vasodilatation, which is seen with ACE inhibitors. Severe renal vasoconstriction can cause AKI, which is seen in sepsis, hepatorenal syndrome, hypercalcemia, certain drugs like calcineurin inhibitors, NSAIDs, hypoxia, hypercapnia, and adrenal insufficiency. Next comes intrinsic AKI, which is seen in 10 to 30% cases. It can affect the tubules, which is referred to as acute tubular necrosis. Acute tubular necrosis may be because of any of the causes of prerenal AKI. So any cause which causes prerenal AKI will progress to ischemic ATN if the renal perfusion is not restored. The next cause would be the nephrotoxic ATN. Nephrotoxic ATN can be because of exogenous toxins like antibiotics, anti-cancer drugs, some immunosuppressive drugs, contrast agents used in CT scans, heavy metals, alternative medications, organic solvents, and venoms like the snake venom. Endogenous toxins, commonly being myoglobin, which is frequently seen with rhabdomyolysis, many infections of the muscles like dermatopolymyositis, certain drugs, severe electrolyte imbalances like hypokalemia and hypophosphatemia, severe hypothyroidism, certain stings, hereditary diseases. Release of hemoglobinuria can also cause nephrotoxic ATN, which is seen with severe malaria, transfusion reactions, again snake venoms and chemicals, and paroxysmal nocturnal hemoglobinuria. Intrinsic AKI can also occur because of involvement of the renal vessels. If the large vessels are involved, including the renal artery and vein, in thrombosis, thromboembolism, atheroembolism, aortic dissection, aortoarteritis, or compression of the vessels by large lymph nodes or other structures. The microvasculature may be involved in thrombotic microangiopathy, antiphospholipid syndrome, radiation nephritis, malignant hypertension due to any cause, scleroderma, or vasculitis involving the kidneys. Any glomerular disease can present as AKI due to like rapidly progressive glomerulonephritis. Tubular interstitium may be involved. It is usually present as an acute tubular interstitial nephritis with a rise in serum creatinine, and it could be because of various drugs, common being NSAIDs, antimicrobials, immunological situations like SLE and acute rejection in the transplant kidney, infections like fungal infections and tuberculosis, neoplastic like myeloma, lymphoma, and acute leukemias. Idiopathic acute interstitial nephritis is known, and in certain diseases like sarcoidosis. Finally, AKI may even develop when urine is being formed normally by the kidneys, but it cannot be passed because of some obstruction in the urinary tract. It is seen with congenital anomalies like posterior urethral valve, neurogenic bladder, and ureterostele. It can be seen with kidney stones, enlargement of the prostate, malignancies of the prostate, bladder, and urethra, cervix, uterus, and other metastatic cancers, retroperitoneal fibrosis, acute uric acid nephropathy, certain drugs, gynecological causes like during surgery, inadvertent ligation of the ureters, uterine prolapse, and certain infections like TB, fungal infections causing fungal balls in the urinary tract, which lead to obstructive uropathy. The causes of AKI vary according to various age groups. As you see here, the elderly and very elderly, obstructive causes are more common compared to the young age, while pre-renal and ATN are more common in the young age groups. Having looked at the various causes, let's briefly look at the pathophysiology of AKI in these conditions. In pre-renal and ischemic AKI, there will be intravascular volume depletion because of various causes, or decreased effective circulating volume. As I said earlier, renal vasoconstriction, decreased cardiac output, large vessel vascular disease, peripheral vasodilatation, small renal vascular disease. In all these situations, there is a generalized or localized reduction in the renal blood flow, leading to ischemic acute kidney injury. Prerenal and ischemic AKI, because of the ischemia, there is endothelial injury which causes activation of vasoconstrictors, impaired vasodilatation, increased leukocyte adhesion. All these factors lead to capillary obstruction and persistent ischemia, which further worsens the endothelial injury. There's inflammation, which further worsens the endothelial injury. And all these factors causes tubular injury, leading to disruption of the cytoskeleton, loss of cell polarity, causing apoptosis and necrosis, desquamation of cells, and That leads to tubular obstruction and back leak. Now, as I said earlier, pre-renal AKI and intrinsic acute tubular necrosis ischemic are a continuum of disease. Initially, when the renal perfusion is impaired, the renal function declines. At this time, the patient is still volume responsive. If the perfusion is restored, his renal functions recover more rapidly. That is the therapeutic window we have. However, if the cause of AKI persists and the renal perfusion is not restored, there is structural damage with tubular necrosis, and at this time the patient may become volume unresponsive. Sepsis is another common cause of AKI, and what happens is there is bacteremia, release of lipopolysaccharides and cytokines, increased inducible nitric oxide synthase causing increased nitric oxide. This leads to glomerular microthrombi formation, systemic vasodilatation, decreased renal endothelial nitric oxide synthase, and tubular damage because of reactive oxygen species. And all these lead to acute renal failure. The bacteremia and endotoxemia with increased nitric oxide causes arterial vasodilatation, as we saw earlier. This has multiple connotations. It acts on the heart, causing arterial underfilling and baroreceptor activation. The cardio-regulatory center of the CNS is activated. There is increased sympathetic tone, causing activation of the renin-angiotensin system, and there is increase in arginine vasopressin. All these factors cause renal vasoconstriction with sodium and water retention. So when there's an ischemic insult, there is hemodynamic injury causing decreased filtration pressure, decreased perfusion pressure, and increased renal vascular resistance, causing ischemia, reperfusion injury, renin-angiotensin aldosterone system activation, necrosis, microthrombosis, back leak, tubular casts, obstruction, loss of polarity, and edema. When there's systemic inflammation because of ischemic insult or in sepsis, there is release of lipopolysaccharides and endotoxins, which can worsen the hemodynamic injury, but can also cause toxic injury, leading to bacterial toxin release, cytokine-induced injury, efferent arterial vasodilatation, TGF activation, microcirculatory dysfunction, apoptosis, endothelial injury, and white cell adhesion. Oxidative stress. Initially, all these factors cause sublethal injury to the cells, tubular cells, but subsequently there may be apoptosis and necrosis, and regeneration may or may not be complete. Purists say that when we talk of acute kidney injury, we should refer only to the ischemic or nephrotoxic tubular injury, that is pre-renal and intrinsic AKI leading to acute tubular injury, while glomerular diseases and vascular diseases, microvascular diseases should not be included. But as of now, when we talk of acute renal failure or AKI, we're referring to all the factors and causes we discussed earlier. Looking at some special situations, pregnancy-related AKI is fairly common in developing countries. The incidence varies from as common as 1 in 50 in India to 1 in 20,000 in developed countries like Italy. And this is again older data. It has become even more infrequent in developed countries now. So it's more common in countries where there's a lack of antenatal care and unsupervised home deliveries are common. We know that the physiological changes in the kidney during the pregnancy, which actually lowers the serum creatinine, increases the estimated the GFR, makes the early diagnosis of AKI challenging. So it is important that the baseline renal function and proteinuria should be assessed in all pregnant females at the baseline, and they should receive adequate antenatal care to prevent this serious complication. When we talk of pregnancy-related AKI, it could be because of pregnancy-related conditions like hyperemesis gravidarum or vomiting due to other complications, or bleeding because of missed abortion, abruptio placentae, postpartum hemorrhage, or intraoperative bleeding or placenta previa, septic abortions, which are especially common when they are tried by quacks or tried at home, postpartum cardiomyopathy leading to AKI. There are certain renal diseases which are characteristic in pregnancy, like acute cortical necrosis or acute tubular injury associated with severe preeclampsia, HELLP syndrome, acute fatty liver or pregnancy, or amniotic fluid embolism. Thrombotic microangiopathy, classically seen with postpartum HUS, but also seen less frequently with other causes. Post-renal causes are less common, but may be seen due to bilateral hydronephrosis or trauma to the bladder or ureters during the cesarean section. Pyelonephritis is a common cause of AKI in the pregnant females. As we know, they are more susceptible to developing urinary tract infections. Sometimes patients may also have de novo glomerular disease or worsening of a pre-existing glomerular disease during pregnancy, leading to an AKI. Cardiorenal syndrome is another condition which is frequently discussed with AKI. Cardiorenal syndrome has now been classically classified into 5 types. Acute cardiorenal syndrome with heart failure leading to AKI. For example, acute coronary syndrome leading to acute heart and kidney failure. Chronic cardiorenal or type 2, where there is chronic heart failure leading to CKD. Type 3, which is the acute nephrocardiac, where acute kidney disease leads to uremia and heart failure. Chronic nephrocardiac, where CKD with uremia leads to left ventricular hypertrophy, diastolic heart failure, and secondary, where systemic disease leads to both heart and kidney failure, as seen in sepsis, vasculitis, diabetes mellitus, and amyloidosis. Management of AKI in patients with pre-existing heart disease is a challenge. It's a separate discussion, which we will not address here. And finally, we come to basic approach to prevention and management of AKI. So when we talk of prevention and management, we look at assessment of the patient. Right, for the first time we see the patient may or may not have AKI. We need to do risk stratification and diagnosis of AKI. Once we have diagnosed or identified the risk factors, we need to remove or treat the cause of AKI, give supportive treatment, and then the patient may or may not require dialysis or renal replacement therapy. So why is risk stratification important? Because in a patient with acute kidney injury, it has many complications. He may have fluid overload, he may have electrolyte or acid-base abnormalities, he may even have impaired immunity, and finally, patients with AKI may progress to chronic kidney disease. And as we saw earlier, AKI in any condition increases the risk of mortality. So question remains in terms of which patients are at the highest risk of developing AKI, and those who develop AKI who are at the highest risk of having the most adverse outcomes. So when we look at factors affecting the outcome, they may be related to the baseline condition of the patient, the cause of the AKI, and the duration and severity. So a patient may have certain risk factors which make him more susceptible to develop kidney injury, like advanced age, female gender, volume depletion due to any cause like diarrhea, chronic kidney disease, pre-existing chronic disease like heart, lung, or liver disease, diabetes, malignancies, and anemia. Now, in the setting of these susceptibilities, if he is exposed to any other challenge, he is more likely to develop an AKI. So which are the exposures which lead to an AKI? Commonly, sepsis, hypotension due to any cause, any acute critical illness, any major surgery, especially cardiac surgery, exposure to nephrotoxic drugs, radiocontrast agents, plants, and animal toxin exposures. So knowing what might go wrong, knowing these susceptibilities and exposures and looking for them proactively in any patient reduces the chances and severity of the complications. So when we talk of risk stratification for AKI, all patients in emergency should have a blood urea, serum creatinine checked routinely on admission, irrespective of the indication for admission. And he should be assessed for the risk factors and the susceptibility for AKI, as we discussed in the previous slide. Now, once a patient has been identified based on these history and the biochemistry parameters that he's at increased risk of AKI, his serum creatinine and urine output should be monitored more frequently for early detection. We should remember that normal creatinine does not mean normal kidney function. The creatinine may be falsely low in many cases, like underweight, females, pregnancy. Also, the GFR or the renal function is age dependent. The normal creatinine may actually suggest impaired GFR in a very elderly patient. So always an estimated GFR should be calculated, and this should especially be done before you give nephrotoxic drugs. So take home message, serum creatinine is misleading for early diagnosis of AKI. In an ICU patient, we just saw that critically ill patients are more likely to develop AKI, especially if they have sepsis. What are the predictors of mortality in these patients? Duration of hospital stay before the onset of AKI, contributing factors like sepsis, cardiogenic shock, or hepatorenal syndrome, the severity of the kidney injury, the requirement for vasopressors, mechanical ventilation, and increasing age. Now, once we have stratified the risk, suppose the patient develops AKI, or we are called to see the patient only when the patient already has AKI, then we need to monitor the serum creatinine, the estimated GFR, and urine output to diagnose and stage the kidney injury. And we need to make a detailed assessment, history and physical examination, lab and radiologic investigations to determine the type and cause of AKI. And subsequent management will depend on this. So clinical evaluation requires a careful history and physical examination, past medical history about any chronic disease or major surgery, drug history like over-the-counter use of painkillers or herbal medications, indigenous medications, or recreational drugs, social or occupational history like exposure to tropical diseases, and a detailed chart review if the patient has been hospitalized for some time to look for treatments received which could lead to nephrotoxic exposure like certain antibiotics and NSAIDs. Symptoms, we should be looking at fever, rash, joint pains, myalgias to rule out infections and autoimmune diseases. Presence of dyspnea or palpitation should sensitize us to the possibility of a cardiorenal syndrome. Diarrhea, vomiting, blood loss suggests volume depletion. Preceding bloody diarrhea could be leading to HUS. Preceding upper respiratory tract infections like pharyngitis could be leading to post-streptococcal glomerulonephritis or any post-infectious glomerular disease. The urine output assessment is important. If there is an abrupt stoppage of urine suggesting an acute obstruction, that should be ruled out. It could be because of a severe acute glomerulonephritis or a sudden vascular catastrophe like a bilateral renal artery thrombosis, though it's very less common. If there's a slow decrease in urine output with other urinary symptoms like frequency or urgency, then we need to look for an urethral stricture or a prostate enlargement. If there is a presence of blood in urine, it could be painless, where it is most likely to be a glomerulonephritis. And if there's painful hematuria, it is more likely to suggest a urethral obstruction. Physical examination is important for evaluation of fluid status and to rule out dehydration. Signs of acute and chronic heart failure, infection, and sepsis need to be looked for. Other signs of systemic disease like skin rash or signs of vasculitis, fundus examination for a hypertensive retinopathy in a patient suspected to have malignant hypertension, signs of atherosclerotic disease need to be searched for according to the history. Assessment of the urine output. Oliguric renal failure is when usually defined as urine output less than 400 ml, while an anuric renal failure in adults is usually referred to as urine output less than 100 ml. As I said earlier, anuric renal failure is less common, and we should always look out for causes of complete obstruction, though it can be seen in patients with severe acute tubular necrosis. So based on the urine output, classification may help to establish a cause. Also, urine output assessment is important for prognosis. It has been shown in studies that the mortality is significantly higher with oliguric AKI compared to non-oliguric AKI, that is 80% versus 25%. And non-oliguric AKI also suggests a greater likelihood of complete recovery of kidney function. Coming on to investigations, of course, the first investigations would be the serum creatinine and blood urea nitrogen and an estimated GFR based on serum creatinine. Electrolytes to rule out hyperkalemia, hypokalemia, or sodium imbalances. A blood gas analysis to rule out metabolic acidosis. A complete blood count and differential to look for infection, as we know sepsis is a common cause of AKI. And then finally, if the patient is producing urine, always check the urine. For the urinary indices, which I will come on to the next slide, urine protein that would suggest the presence of a pre-existing chronic kidney disease or a glomerular disease. Urine sediment, the presence of eosinophils may suggest an acute interstitial nephritis. The presence of a WBCs in urine or leukocyte casts could suggest an infection or an acute interstitial nephritis. Presence of RBCs again could suggest an acute glomerulonephritis, and various crystals may also be helpful. When we talk of intrinsic AKI, if the patient has nephrotic proteinuria and dysmorphic hematuria and red cell cast, it suggests a glomerulonephritis, less commonly a thromboembolic disease or thrombotic microangiopathy. If you have oval fat bodies or fatty casts in urine, possibility of minimal chain disease in FSGS. If the proteinuria is less in the tubular proteinuria range, then it could be because of tubular epithelial injury or because of tubular interstitial nephritis or a urinary tract infection. Presence of crystals could suggest drug toxicity, urate crystals leading to urate nephropathy, and calcium oxalate crystals suggesting ethylene glycol intoxication. Urinary indices were considered to be important to differentiate between acute tubular necrosis and prerenal AKI. Patients with prerenal AKI would have, it is a sodium avid state, so the kidneys try to reabsorb all the sodium, so urine sodium is low. The fractional excretion of sodium is supposed to be a good marker to differentiate the two. It's calculated using the urine sodium and plasma creatinine as shown here. And the FeNA is always less than 1% in prerenal AKI, or it will be higher in patients with acute tubular necrosis. However, there are certain exceptions. The FeNA may be less than 1% in even other conditions like early acute tubular necrosis or other sodium avid states like cirrhosis and nephrotic syndrome or acute obstruction. And again, if you're treating a prerenal AKI with diuretics, the FeNA will be falsely high. The blood urea creatinine ratio is also a good marker. The urea is disproportionately higher to creatinine in patients with prerenal AKI, but then again, it can be elevated in other conditions where there's increased urea production or reabsorption like GI bleed, TPN, use of steroids, and certain drugs like tigecycline use. Coming to radiology, every patient of AKI should get an ultrasound examination done. If we don't have a baseline creatinine, the presence of small kidneys would suggest a pre-existing chronic kidney disease with an acute insult superimposed. And of course, an ultrasound helps us very much in ruling out obstructive disease, though we should remember that bilateral hydronephrosis may be absent in patients with acute obstruction. So, when we diagnose kidney injury, we need to rule out is the renal failure acute or chronic. The laboratory values will not always discriminate. So, we should look for clues to chronic disease like pre-existing illness seen in diabetes, hypertension, increased age, or vascular disease. Presence of long-standing uremic symptoms like fatigue, nausea, anorexia, pruritus, altered taste sensation, and of course, as I said earlier, small echogenic kidneys by ultrasound. And the diagnostic steps have to be taken according to the initial etiology. So if we think that it's a decreased renal perfusion, then we need to look at the volume status and the urine diagnostic indices. If you're suspecting a GN, an interstitial nephritis, a vasculitis, a TMA, urine sediment examinations, serologic testing, and hematologic testing are important. And as in obstructive disease, and kidney ultrasound is important. Sometimes subsequent investigations also depend on underlying disease. Like if you're suspecting myoglobinuria, suppose a patient has a history of crush injury and then comes with a rise in creatinine, then looking at the CK and the free myoglobin in urine is important. For sepsis, an investigation for sepsis like chest x-rays, blood films, blood cultures, inflammatory markers, assays to detect specific antibodies for vasculitis, collagen disease, or glomerulonephritis, peripheral smears, and LDH for TMA. There are various investigations like this. Biomarkers for AKI, early diagnosis of AKI are still in a research state, not routinely used clinically, though some centers have used it, especially in early diagnosis of AKI after cardiac surgery. The advantage is that it can pick up AKI very early, even as early as when the patient has an increased risk of developing kidney injury. Finally, renal biopsy, it's not routinely used. It should be done only when we have ruled out all pre- and post-renal causes of AKI. The clinical findings are not typical of an acute tubular necrosis, or there are extrarenal manifestations that suggest a systemic disorder. The patient has a heavy proteinuria or active urinary sediment suggesting glomerular disease. And the clinical and laboratory radiological evaluation does not establish the diagnosis with certainty. Once we've diagnosed AKI, we need to remove or treat the cause of AKI. It's a heterogeneous disease with multiple triggers. As we saw earlier, majority of the causes of AKI are perirenal because of a compromise, in which case hemodynamic resuscitation is required, or there is a nephrotoxic AKI or a drug-induced acute interstitial nephritis, where sometimes just the withdrawal of the offending drug will suffice. Specific management depends on etiology. Like sepsis, you treat the sepsis with antibiotics, optimize the cardiac status in cardiorenal syndrome, immunosuppression for vasculitis or autoimmune diseases or glomerular diseases, plasmapheresis for HUS, and relieving obstruction for postrenal AKI. Hemodynamic resuscitation is important. Hypotension due to any cause results in decreased renal perfusion. The autoregulation maintains relatively constant renal perfusion despite changes in blood pressure till a mean arterial pressure of 65. Below that, renal perfusion is impaired. So correction of volume deficit is essential to minimize further extension of the kidney injury and facilitate recovery of the AKI. But we have to be careful, especially in a patient who is oliguric, because hemodynamic correction may lead to volume overload and lead to even acute pulmonary edema, causing increased mortality. We need to assess the hemodynamic status. Physical examination for signs of dehydration, fluid overload may not always be accurate. Sometimes in critically ill patients, invasive monitoring is required, like central venous pressure, intra-arterial blood pressure, dynamic variables like pulse pressure variation or IVC filling by the ultrasound, and echocardiographic appearance of the heart. And we should do a blood gas analysis for oxygenation. Isotonic crystalloids are the fluid of choice rather than colloids for initial fluid resuscitation. There's a lack of clear evidence that colloids are superior, and specific colloids like HES may actually cause osmotic nephrosis and worsen the AKI. High molecular starches can cause coagulation defects, and of course, all colloid solutions are much more expensive. Colloids may be chosen in some patients to aid in resuscitation goals, to avoid excessive fluid administration in patients requiring large volume resuscitation in special situations like burns patients or patients who have cirrhosis with spontaneous peritonitis. Vasopressors are important in patients who have persistent hypotension despite optimization of intravascular volume. It should be used in conjunction with fluids in patients with vasomotor shock. Norepinephrine is the first-line agent, especially in patients with sepsis. Vasopressin should be used in patients who are refractory to norepinephrine. Dopamine is no longer routinely recommended because it has been associated with decreased survival and increased adverse events. A goal-directed management is recommended, protocol-based management of hemodynamic and oxygenation parameters to prevent development or worsening of AKI in high-risk patients, especially in situations like perioperative or septic shock. Goal-directed therapy means hemodynamic monitoring with predetermined target values with a time limit to reach these goals. So early goal-directed therapy in septic shock, hypotensive patients with severe infection are rapidly assessed for tissue perfusion using a mean arterial blood pressure and plasma lactate levels. Resuscitation protocol is initiated with the goal of re-establishing tissue perfusion within 6 hours of diagnosis. The goals are a mean arterial pressure of at least 65 millimeters of mercury, a CVP of 8 to 12 centimeters of water, improvement in blood lactate levels, a central venous oxygen saturation score of more than 70%, and a urine output of more than 0.5 ml per kg per hour. Minimizing nephrotoxic exposure is important. Always look at a drug chart in a patient with AKI. They're implicated in 10 to 30% cases of AKI, and known nephrotoxic drugs that should be avoided in high-risk patients. Aminoglycoside use should be minimized and avoided if possible. If it has to be given, give as a single dose daily rather than multi-dose treatment regimens, and therapeutic drug monitoring is recommended. Lipid formulations of amphotericin B are believed to be less nephrotoxic than the conventional form. Radiocontrast agents should be used with caution. Lowest possible volume of isoosmolar or low osmolar iodinated contrast medium, and volume repletion is important. Supportive management, insulin therapy to keep plasma glucose within limits. Anemia might need correction. Drug dosing should be adjusted according to the renal function. Stress ulcer prophylaxis is advisable, and most importantly, prevention of infection is vital. Diuretic therapy has been used in managing volume overloaded patients with oliguria to convert them into non-oliguric AKI, but should be used with caution because sometimes it is ineffective. It may worsen the AKI, the prerenal component, and by exacerbating the volume depletion, low-dose dopamine should not be used. Maintaining nutrition is important as these patients are hypercatabolic. Enteral route of nutrition should be preferred. Energy intake should be around 20 to 30 kilocalories per kg per day. And the protein intake should be around 0.8 to 1 gram per kg per day in non-catabolic patients who do not need dialysis. And it should be the protein intake should be increased in patients who require dialysis. And finally, coming to dialysis, the optimal timing when dialysis should be started in a patient with AKI is not defined. The dialysis modalities available are intermittent hemodialysis, sustained low efficiency dialysis, continuous renal replacement therapy. And finally, peritoneal dialysis, acute PD, is not commonly used because of its certain limitations. CRRT and SLED is typically used in hemodynamically unstable patients. The typical indications of AKI, dialysis in AKI would be severe anuria or oliguria, severe hyperkalemia, severe metabolic acidosis, volume overload, patients who do not respond to diuretics, severe uremia and related complications. In oliguric anuric patients, it helps in volume control and allows nutritional supplementation and delivery of drugs, and is important for regulation of acid-base and electrolytes and reducing the solute burden. Most of the studies which have compared CRRT to intermittent hemodialysis have not shown any benefit on outcome of AKI or hospital stay. In this particular study, in NDT 2009, a comparison of a renal replacement therapy modality showed no benefit impact of the type of RRT given on the duration of hospital stay, the mortality, and even the residual risk of chronic kidney disease. But yes, the need for dialysis in a patient with AKI is associated with poor outcome. In this study, comparing outcome in patients with AKI who were managed conservatively to those who required dialysis, there was a significantly higher mortality in patients who required dialysis, and they also had a longer hospital stay. Now, coming to CRRT versus SLED, these are two modalities which are usually used in patients who have AKI with hypotension. Now, CRRT is more expensive, SLED is more readily available. In the study comparing 158 patients who received CRRT with 74 patients receiving SLED, the all-cause mortality at 30 days was similar in both the groups, suggesting that both CRRT and SLED are equally useful in treating these patients. Acute PD is not routinely used or recommended in patients with AKI, but still it is frequently used in middle and low income countries where there's a paucity of infrastructure to give hemodialysis. There are studies which have suggested in the Cochrane database has suggested that there is little or no difference between PD and HD for treating AKI as far as mortality and recovery of AKI is concerned, as far as infectious complications or correction of acidosis is concerned. However, it is not commonly used because it is believed that fluid removal and weekly delivered KTVIV may be much lower than in PD compared to HD. There is no control on the fluid removal and there are limitations in clearance. So, lastly, the KDIGO has suggested there should be stage-based interventions in AKI. In patients, initially with all patients, but even in high-risk patients, we should discontinue all nephrotoxic agents when possible, ensure volume status and perfusion pressure. These factors are important to prevent AKI in those who are high risk, and it's also important in preventing progression once AKI has already developed. Consider functionally hemodynamic monitoring, especially in critically ill patients. Serum creatinine and urine output should be monitored more frequently. Hyperglycemia should be avoided. Radiocontrast procedures should be minimized. Non-invasive diagnostic workup should be intensive. And as the disease progresses, more and more invasive diagnostic workup may be required. As AKI is a dynamic process, so patients should be checked regularly for changes in drug dosing as the disease severity increases. And renal replacement therapy should be started whenever needed. ICU admission is recommended, especially in critically ill patients who develop AKI, and subclavian of catheters should be avoided in these patients for giving dialysis as far as possible. And finally, monitoring patients with AKI, we should remember that 30% of patients in whom survive after an AKI will have residual renal impairment and discharge. So they are at high risk of developing chronic kidney disease. They should be evaluated at 3 months after discharge for resolution, new onset, or worsening of CKD. If patients have CKD, then they should be managed accordingly. But even if they do not have residual disease, they should be considered at an increased risk of developing chronic kidney disease and cardiovascular disease in the future and should be monitored accordingly. To summarize, AKI is common, especially in hospitalized patients. Syndrome is multifactorial, so we should look for all causes. It imposes a heavy burden on illness because cost of managing an AKI is high and outcomes are poor. However, it is amenable to early detection and potential prevention, especially hemodynamic resuscitation and avoidance of nephrotoxics. So high index of suspicion and close monitoring is required, and there are further research is needed to develop biomarkers for early diagnosis and prognostication.